Tēnā koutou katoa, and thanks to Peter and Claire for the invitation to speak today. I'm coming to you from Tamaki Makarau, Auckland, in Aotearoa, New Zealand. So, for many years, hopefully all of us have been delivering a degree of personalised medicine to our patients, taking into consideration their specific disease, severity, age, personal circumstances. And precision medicine just really adds another layer onto that, where we now take a person's genetic makeup into account. This is the opposite to one treatment or one size fits all, and it's not really new. I mean, we've been giving blood transfusions or organ transplants for years. So the context of precision medicine really takes into consideration lots of different parameters. By understanding the pathway involved or an aberrant pathway involved in disease, we can target drugs or repurpose drugs. By knowing a person's genetic makeup, we can determine their risk of developing a disease, the severity of that disease, how it may progress with time, and certainly attempt to target the treatment most effectively. So as opposed to the monogenic diseases down the green end of the spectrum here are ones that we've heard about. You have a rare deleterious change in a gene that has a big impact on the disease development, such as the inherited retinal diseases. And we've heard about treatments that target these genes either by targeting the pathway involved with oral medications, or as Keith talked about, by targeting the specific gene with gene replacement therapy, or targeting a specific mutation in a specific gene, as we've seen with antisense oligonucleotides and gene silencing and editing with CRISPR. Complex diseases, however, are a little different. Here we have multiple genes that don't directly cause disease, but they predispose an individual to developing a disease, particularly when you have multiple factors, and then they're all bathed in the milieu of the environment. So now we're down the blue end of the spectrum, where we have gene changes that in themselves do not cause disease. They might be quite common in the community, but they predispose an individual to develop disease. And if there's multiple of these genetic variants predisposing a person to disease, they can add up, and these contribute to these complex diseases. So many of us are familiar with this Manhattan plot from a genome-wide association study for macular degeneration, where multiple loci have been identified. And if we just look at these three loci, the CFH arms 2 and HTRA, individually, each one can increase the odds of a person developing macular degeneration greater than the general population. Sorry, I seem to have lost my clicker. Up to a factor of 12. And if we combine those three factors together, then an individual in the red there has a far greater risk of developing macular degeneration than somebody who does not have those three variants. So can we use this information to target or tailor prevention or treatment? So the ARIDS-2 study, Klein reported that those with the low-risk CFH allele who took antioxidants, less of them progressed to advanced disease compared with those with the high-risk allele. But by definition, those with the high-risk allele were at greater risk anyway. Carl Orr caused a bit of a stoush. He retrospectively looked at the 10-year ARIDS data and reported that if you had a certain genotype, if you took zinc, for example, you were predisposing yourself to a poorer prognosis, or if you had a different genotype, taking antioxidants might be difficult or make you worse. And then Emily Chu and the ARIDS group came back and said, actually, it didn't make any difference. But Carl Orr doubled down and actually said, yes, the genotype does predispose you depending on what supplement you take. So clearly there's more work to be done in this space. Does our genetic makeup determine our treatment response to anti-VEGF? Well, yes, it's complicated. Some SNPs do increase a better prognosis, such as this one, greater than you would expect, a better prognosis, whereas others have a poorer prognosis. And if you combine these all together, you get a polygenic risk score. And there's many of these out there. This paper showed that some higher polygenic risk scores required more treatment and retreatment than those with a lower polygenic risk score. Similarly, for glaucoma, most of it is polygenic, and not only are there multiple loci, these loci can be associated with specific endophenotypes such as intraocular pressure, the central corneal thickness or optic nerve head parameters. And Jamie Craig and the ANSRAG group looked at all these multiple trait loci and analysed them in conjunction with optic nerve head appearance from a lot of UK Biobank participants. And not only did they identify known loci, but also novel loci, and these correlated quite nicely with the ANSRAG and neighbourhood consortia. And then they created polygenic risk scores, and those in the top in the highest decile actually had a 15 times greater odds ratio of developing glaucoma than those in the lowest decile. And those, the area under the curve showed 80% sensitivity. And clinically, this meant that those with the highest polygenic risk score developed disease on average 10 years earlier than those in the lowest. Their baseline nerve fiber layer was thinner to start with, so that's a good indication of progression. And also they were much more likely to require trabeculectomy. So now you can start tailoring your individual treatment monitoring to a person's makeup, genetic makeup. Similarly, our genes determine our response to certain topical medications such as beta blockers or latanoprost. And the last complex disease really is diabetic retinopathy. And it's not just how severe your metabolic control is or how long you've had disease. There certainly is a heritable component, as shown with twin studies. Multiple loci, yet again, identified. Some of them are our old friends, like VEGF. We also have ones associated with vasodilation, like nitric oxide synthetase. And the main pathways they're involved in: insulin signaling, angiogenesis, inflammation. And then by using expression patterns, we can see that individuals with a certain FLCN variant and develop diabetic retinopathy have a really statistically significant upregulation with this gene in response to high sugar. So if we look at the transcriptome analysis, so this seems to have a life of its own. If we look at the transcriptome analysis, we can now identify those on one side with diabetic retinopathy who respond to higher glucose and develop retinopathy, as opposed to those who don't. So we can now target those who need to be screened more effectively. So what does this mean? Well, I think we're all pretty much used to this by now. And technologies over COVID developed rapidly. So we have rapid antigen tests or LAMP testing. And hopefully within a few years, we'll be entering the eye clinic. We get one of these kits and hand it to our clinician, and we'll be able to personalize the individual treatment we give to people based on their risk of developing disease, the severity of that disease, preventative measures that might help with their disease, specific interventions to treat that disease, and hopefully also open the way to developing new drugs and surgeries. So ngā mihi, and thank you very much.